Hi everyone, so we are starting a video today and we'll speak about psoriasis. We'll talk about histopathology and differential diagnosis of psoriasis. And I'm Dr. Victoria Kozlowska. I'm an assistant professor in University of Pittsburgh, dermatology and dermatopathology departments. And I have here our fellows, John Mash and Ijiruchi Keka. They are wonderful and they will also speak a little bit about clinical presentations and histopathological correlation of psoriasis.
So I'm going to be talking about psoriasis and mostly going to be going over the clinical subtypes that we see in psoriasis. First, psoriasis is very complicated. The pathophysiology is very multifactorial, but our current understanding is that this is an immune-mediated disorder. T cells play an important role, as do multiple different cytokines, and we utilize a lot of these cytokines in the treatment of psoriasis. So let's go over these cases now. So this is your classic plaque psoriasis. It's a well-circumscribed erythematous scaly plaque. You can even see in the upper left corner there may be some bleeding, and this is common in psoriasis plaques. It's called Auspitz sign. It's due to dilated capillaries in the dermatopathology. And when the patient scratches the lesion, they're so superficial to the skin surface that it'll actually will show up as pinpoint bleeding. And then also, which is pretty neat, is sometimes people call the scale in psoriasis micaceous because it actually looks like this scale of micaceous scale on rocks, which I found interesting. This is another good case of plaque psoriasis, and this patient, what it's showing is Kebnerization, and you see that this patient has some classic plaque psoriasis, but also this diffuse distribution in areas that he was scratching, and that's what you get with Kebnerization. You have more plaques surrounding areas of trauma. So that's what we tell patients, to try not to scratch the area. So this case is showing early plaque psoriasis, and it fits for skin type. These can be challenging to diagnose on clinical alone. You have to suspect it, maybe look at the nails, look at other areas of the body to try to confirm it. But what you see here is a lack of obvious scale that we saw in the prior plaque psoriasis cases, and maybe you thought this could be nummular dermatitis, maybe you thought this could be tinea, but biopsy did confirm this to be early plaque psoriasis. This is an example of classic symmetric plaque psoriasis. So, when we classically learn about this, we think of, symmetric distribution on the elbows, knees, retroauricular areas, maybe the scalp. So always check these areas to help confirm psoriasis in a patient that doesn't have a classic presentation. This is another example of maybe a partially treated plaque psoriasis, almost macerated. You do see scaling, and I would, bilateral would be atypical, but you can get maybe tinea, so maybe scraping this with KOH would be beneficial to the patient to confirm tinea, but ultimately this case ended up being a case of psoriasis. This is a case of inverse psoriasis, and what we see here that we don't see in a lot of the other examples of plaque psoriasis is good scale. So when you have psoriasis in areas where maceration is prevalent, you can lose scaling, and that can make it challenging to diagnose it. And especially in these areas, we always think, oh, is it classic intertrigo from irritation? Is it candida? We don't see any pustules here. Satellite pustules are lacking. It is, pretty. We call it kind of like glassy red, and it's almost violaceous in this area. So always think about, am I missing psoriasis when you see this kind of shiny, glazy erythema in folding areas, because it could be inverse psoriasis. Other things to rule out are like tinea, as well as like allergic contact, irritant contact, dermatitis. So this is actually a pretty challenging case of guttate psoriasis. The plaques, the little circumscribed plaques with scale aren't as well developed as you typically see, and these have almost a little more follicular involvement too, that you'd be considering. Could this be folliculitis? Could this be pleba? Could this be some other inflammatory disorder? But as you can see up in the top left, you see kind of a more typical guttate lesion with some little micaceous scale on top of this well circumscribed plaque, and you can see a couple others. And then, what you typically ask the patient is, have they had a sore throat, maybe they've had perianal strep, because these typically follow streptococcus infections. So you can do ASO titers, anti-DNase titers on these patients, and even treating the strep infection will help make this go away. I have seen younger patients having gut tape psoriasis that actually, a percentage of them can go into having plaque psoriasis later, so you have to follow them up. And this is just another picture from more the lateral leg and the anterior part of a gut tape psoriasis patient. This is a case of erythrodermic psoriasis. Erythroderma is just kind of full body erythema. Some textbooks say 80%, some say 90%. There's a broad differential for this. The most common known cause of erythroderma is going to be psoriasis, but you could think about atopic dermatitis, you have to think about mycosis fungoides. Idiopathic erythroderma happens in a kind of more of an elderly adult population. They get like lymphadenopathy. There's tons of different differentials depending on the age. Some rare things can happen in kids compared to adults. So you got to keep your differential broad. What would help here would be looking at like toenails, looking at joints for maybe enlarged joints, so looking at onycholysis, pitting, and salmon patches, or oil spots in the nail plate. But also the scaling too is something that you can look for too. I think that's probably good for psoriasis. PRP would be on the differential too. You look for more sparing there and follicular-based papules and more of a cephalocaudate distribution of the lesions, which I don't believe was in this case of erythrodermic psoriasis. Pathology would obviously be helpful in making the diagnosis. What's important to know about this too is the patient can also have some more hemodynamic instability, which might require different treatments quicker than you would do for normal plaque psoriasis. This is an interesting case showing verrucous psoriasis, and the differential here again is broad. Biopsy is going to help you. You have these pretty well circumscribed plaques with like pretty severe scale. Could this be verruca? Could this be hypertrophic lichen planus? Could this be hypertrophic lupus? Could it be prurigo? LSC. These are all differentials. Honestly, I'd even keep like verrucous cutis on this, like TB infection. Could this be like some weird atypical mycobacteria? So you have to keep all these on the differential. Even porphyrating would be in the differential for me. So always keep a broad differential, and if you do see psoriasis like findings, especially like a verrucous variant, consider that being verrucous psoriasis. Again, and this is another subtype of psoriasis, which is pustular psoriasis, and you see nice, these are sterile pustules and a background of erythema and even some maceration, and some areas have a little bit of a scale too. For these patients, you have to think about, was this from hypocalcemia? They have an infection with some medication. There's a broad differential of causes that can lead to pustular psoriasis. We also think of things like rapidly tapering, systemic corticosteroids, even like strong, class 1 topical steroids, leading to this. So that's why we typically don't do that as a treatment. But the differential is broad. AGEP could be thought of, acute generalized xanthomatous pustulosis, along with other infectious disorders as well. Sen Wilkinson also crossed my mind, like IgA, pustular dermatosis, subcorneal pustular dermatosis as well.
Okay, so now we'll go over the histology of some common variants of psoriasis. So here there's regular epidermal acanthosis. Within the stratum corneum, there are mounds of perikeratosis with neutrophils or Monroe microabscesses, as well as intraepidermal pustules. There's thinning of the suprapapillary plates, along with dilation and tortuosity of superficial papillary vessels. So this is a classic lesion of psoriasis. In this example, we have mounds of perikeratosis, again with neutrophils, as well as hypogranulosis, mild spongiosis, and there's focal thinning of the suprapapillary plates, along with elongation and tortuosity of superficial papillary dermal vessels. Without epidermal acanthosis. This is an example of guttate or eruptive psoriasis. In this example, we have marked hyperkeratosis and perikeratosis, overlying epidermal papillomatosis. There's thinning of the suprapapillary plates with loss of the granular layer, elongation and dilation of superficial papillary vessels, and regular epidermal acanthosis. There's a slight inward bowing of the rete, reminiscent of a verruca. However, there are no chondrocytes or hypergranulosis. So this is an example of verrucous psoriasis. In this example, there's hyperkeratosis, and there's a large intraepidermal pustule, in areas of perikeratosis and hypogranulosis. And there's epidermal acanthosis. This is an example of palmar plantar psoriasis.
And finally, I will talk about differential diagnosis of psoriasiform dermatitis, psoriasis versus all other inflammatory conditions. And differential here is very, very broad, and I will only be able to mention a couple most common conditions and most difficult differential. So in the first example of seborrheic dermatitis, there is also psoriasiform hyperplasia. However, we see diffuse, although subtle spongiosis. And quite pathognomonic sign of seborrheic dermatitis is presence of mounds of parakeratosis, sometimes with neutrophils in the follicular ostia. However, when they are absent, it's quite difficult to differentiate these two conditions, and sometimes taking a biopsy to differentiate these two is kind of futile because treatment is essentially the same. The next case of differential is pityriasis rosea. And pityriasis rosea can be a little bit acanthotic, especially if you biopsy a herald patch or more chronic lesion of the condition. It also has a little bit of more spongiosis compared to psoriasis. However, some forms of psoriasis are really spongioric as well. And the characteristic feature of pityriasis rosea is presence of small mounds of parakeratosis with serum right above those foci of spongiosis, as we can see here. And in the literature, we always have mentioning extravasated erythrocytes, but they are not always present in pityriasis rosea biopsies, especially again if the biopsy was taken from more long-standing lesion. Extravasates are also common in psoriasis, so this feature is more a feature of acute process rather than a really specific one to differentiate between conditions. The next example is EGEP, and this is a drug-induced condition. We see a little bit more spongiosis and subcorneal neutrophilic pustules. Sometimes one can see a little bit of eosinophils in those pustules. However, it's not in all cases that happens. And here in this particular case, one can see a couple eosinophils in the infiltrate that is a little bit suggestive of a drug reaction. There is also a little bit of hint of interface, which is very common for drug reactions. And I am trying to find an prominent eosinophils, but in this case they are really sparse. And sometimes it's almost impossible to differentiate between EGEP and eruptive pustular psoriasis. Clinical pathological correlation is required, and sometimes time and history of drugs that patient is taking is necessary to do a definitive diagnosis. The next case I would like to present is this hydroid eczema, and we can see that we are in the acral skin because we have compact hyperkeratosis with lamina lucida, and here there is a pustule very similar to the one we have seen in psoriasis. However, if we go closer, there are more lymphocytes and there is also adjacent spongiosis, which favors this hydroid eczema versus psoriasis. And if we go along this biopsy, we can see that this hydrosis is quite widespread, so it's not only in the focus of the pustule, but it's throughout the epidermis, and it's very still similar to the pustular psoriasis on the palms and soles. The next differential is prurigo and lichen simplex. It also has psoriasiform acanthosis with compact stratum corneum. Compared to psoriasis, we don't see parakeratosis, although sometimes it can happen in small foci, and we don't have neutrophils. When we go to the dermis, one can see vertical collagen streaks. That is a feature of chronicity and chronic rubbing, as well as hypergranulosis. That is very typical for lichen simplex. And sometimes we also see so-called Montgomery cells. Those are multinucleated cells that are characteristic for lichen simplex chronicus. However, this feature is quite rare, and this case doesn't have it. If we see a little bit of a dome shape of the papule, we can favor prurigo nodularis. And if it's more like diffuse, like a plaque, then the diagnosis is favoring lichen simplex. The next case is also a little bit similar to psoriasis. It's a granular parakeratosis. So here we can see extensive basophilic stratum corneum, and when we go to the high power, we can see extensive retention of nuclei, which is a little bit similar to chronic eczema or psoriasis. However, it's more intense and there are no neutrophils in the horn. I think location, knowing the location is always helps, because granular parakeratosis is located usually in the intertriginous areas, and usually there are no vessels, tortuous vessels, and the infiltrate is quite minimal. The next case is Psoriasis rubra-pilaris. It can be really difficult to differentiate with psoriasis, and you need a lot of suspicion and good clinical pathological correlation. This is not a very classic case of rubra-pilaris. However, we can see alterations of compact parakeratosis with hint of compact horn with hint of parakeratosis, with areas of normal stratum corneum, which we call orthokeratosis. And here this alteration is in vertical columns. So here is a column of para, and then orthokeratosis, again a piece of para, and orthokeratosis. And sometimes you also see this alteration in a horizontal manner, and that creates so-called checkerboard pattern of stratum corneum. However, I would say that this distinction is really difficult, and a patient has to be examined for keratoderma, for nail abnormalities, and full body skin exam is highly needed. The next case resembles psoriasis a lot, and we can see regular psoriasiform hyperplasia of the epidermis. We can see parakeratosis with neutrophils in stratum corneum. However, there is a very interesting finding consistent with a pallor of the upper part of the epidermis, and this case represents nutritional deficiency, which can have different presentations. However, in classic variants, it has this specific pallor of the epidermis that helps us to make a specific diagnosis. And I would say that this condition is relatively common. We tend to think only about zinc deficiency in kids. However, elderly people with multiple comorbidities, hospitalized patients, they often have nutritional deficiencies, and they can present with variable rashes, starting from macular, squamous rashes, papules, vesicles, and sometimes bullous. So when you see something that you can hardly put into any category, always think about nutritional deficiency, especially in severely sick patients. And this case, from the low magnification, you can think about tortuous vessels of psoriasis. However, see how thick the vessels are. So most likely this biopsy is just taken from a lower extremity, and this is not true tortuous vessels typical for psoriasis. So we'll go to the next case, and this is a differential with spongioric dermatitis or spongioric eczema. We can see extensive spongiosis that on low power somewhat mimics subcorneal pustules in psoriasis. However, if we go on high power, we can see that those are actually Langerhans cells. They have those bean-shaped nuclei and larger amount of cytoplasm, so it's not actually neutrophils. We also see a lot of prominent desmosomes. That's characteristic for intense spongiosis. And it's virtually impossible to make a definitive diagnosis of what exact process we are dealing with based on histopathology only. We need clinical pathological correlation. When eosinophils are present, and they are focally present in this case, so here a couple of them are easily identifiable, we tend to favor allergic contact dermatitis. We tend to favor drug reactions, insect bite, or atopic dermatitis. However, sometimes it's not that straightforward. The next case is quite interesting, and we can see psoriasiform hyperplasia mimicking psoriasis, and also compact stratum corneum. And here, if we go to their higher magnification, we can see that there are no apparent neutrophils in the stratum corneum, but there are foci of parakeratosis, and there are even a couple vessels that mimic psoriasis. However, we have to know a little bit of a history. So this particular lesion is taken from a genital area. And when you have a history of persistent plaques in the genital area, one condition one can think about is pityriasis porokeratosis ptychotropica, which can present as persistent psoriasiform plaques. And here is a hint of a chronoid lamella, and with foci of necrotic keratinocytes at the bottom of it. So it's a collection of parakeratotic cells, usually oriented 45 degrees towards the epidermis, and couple necrotic keratinocytes in the epidermis. Let's see if this case has more prominent chronoid lamellae. Okay, here on the other side it's a little bit better seen. So there are more these keratotic cells at the bottom of the chronoid lamella, and you can see how it emanates from the epidermis at 45-degree angle. The next case is cool. Just to remind that having psoriasiform hyperplasia, it's not always inflammatory. You have to always examine a horn more carefully, and sometimes you can see some unusual guests here. Like here, for example, in a case of Norwegian scabies. So we see multiple scabiatic mites right here, and that's a cool case of Norwegian scabies. And the last case, we can see that it's a well-circumscribed lesion with a little bit of a paler central part, well demarcation from normal epidermis here. So this is a classic example of clear cell acanthoma, and without the history that it's a single lesion, it's always easy to misdiagnose it as a psoriasis, because not always this clear cell abrupt abrupt border is seen, and clear cell differentiation is not really clearly apparent in all cases. Sometimes you can use PAS stain to highlight those cells if you are in doubt. Presence of neutrophils is also characteristic for clear cell acanthoma, and here in this case we also can see a little bit of high up blood vessels. However, it could be just a lesion taken from the lower extremity. So these are the most common differential diagnoses. Of course, there are much more of them, and I hope you enjoyed this short lecture.